of the webinar of Young Guns organized by the Delhi chapter this time. And after the stupendous success of part one, I really look forward to the kind of cases that are coming from Delhi. I should congratulate the Delhi chapter for the kind of, for creating such talent within the city, the kind of cases we are seeing, the confidence which we represent, the follow-ups they are taking are absolutely stunning. I'm really looking forward to the part two, and I wish everyone the best. Looking forward to you. Over to you, Dr. Jaya Chawla and Dr. Sumitra.
Good evening,
Thank you so very
everyone.
much, sir, for those very kind words. Dr. Sumitra, we invite you for your words.
Yes, so thank you so much. After the stupendous success of the first part, and I think we got a lot of messages, and there were like many more people who were very, really waiting for the second part to come on. And again, I would say that Society of Fetal Medicine is committed towards promoting excellence. And sometimes we are gently pushed, sometimes we are goaded by our Professor Emeritus Khurana sir, Mohit Shah sir, all the national faculty, Dr. Aparna, like we have some amazing national faculty with us. So we are looking forward to the fresh young guns now, and we have some very exciting case discussions coming up. So be there with us, and I'm sure you will really feel that your time was very well utilized. Thank you so much. Over to you, Dr. Jaya.
Thank you so very much. And we invite our first speaker tonight, Dr. Ayush Jain, to please share his slides. We anticipate the diagnosis of posterior fossa malformations in the second trimester of pregnancy. However, a de novo diagnosis in the third trimester spells a tumultuous course not only for the prospective parents, but also the clinician. Dr. Ayush Jain, today an alumnus of AIIMS Delhi for his undergrad and postgrad, and a fellow Bangalore Fetal Medicine Center, traces one such course for us. All yours, Dr. Ayush.
Ma'am, am I audible?
Very much.
Yes, ma'am. Thank you for that very kind introduction. A very warm good evening to my respected seniors and fellow audience members. I will be talking about a case that we saw recently of multiple CNS defects noted in the third trimester. I would like to thank the SFM for giving me the opportunity to present our work. So our patient, Mrs. ABC, was a 35-year-old lady. She's gravid 3, para 1, live 1, with previous 1 miscarriage. She already had an eventful pregnancy in the past. She has an 8-year-old boy. In that pregnancy, she had early onset preeclampsia and also had to undergo preterm cesarean in view of severe preeclampsia at 35 weeks, giving birth to an SGA baby, and also had a difficult course in that pregnancy. She has history of 1 miscarriage. She was a known chronic hypertensive for the past 6 years, managing on oral antihypertensives. The family's history was significant for hypertension. There were other medical risk factors such as class 3 obesity. She had a BMI of 41, moderate iron deficiency anemia, and gestational diabetes. So this patient had her antenatal course actually in UAE and presented to us in the third trimester. Just reviewing her history from the past, in the first trimester, she had history of post-conceptional folic acid intake. She underwent a combined first trimester screening, which was low risk for common aneuploidies, but in view of her past history, was started on aspirin prophylaxis for prevention of preeclampsia. She continued taking oral antihypertensives in the first trimester and was controlled accordingly. In the second trimester, the anomaly scan was unremarkable. GTT test was suggestive of gestational diabetes, for which she was on dietary control and continued to titrate with the blood pressure medications for the preeclampsia that she was having. In the third trimester, she had an elective scan with the fetal medicine specialist in UAE, which brought about a sudden diagnosis of posterior fossa defect and with bilateral ventriculomegaly, and underwent TORCH screening over there, which showed CMV immune status at that time. They flew to India because they were told that there was very little that could be done for them over there, with the expectation that our laws would be a little more friendly for them. So I will be sharing a few images from that scan. So on the transventricular plane over here, the anterior complex could not be well visualized. This is cavum septum pellucidum was not visualized. The anterior horns also appeared to be dilated. There was ventriculomegaly seen bilaterally, measuring up to 11 to 12 millimeters. So going down on the sweep, in the transcerebellar view, we could see the cerebellum measuring less than the first centile for the gestational age also appeared to be hyperechogenic. There was loss of arborization of the cerebellar folia seen in the third trimester. There was also prominent cisterna magna. Going further down, we could see a communication in the open fourth ventricle with the cisterna magna, and posterior fossa cyst was noted. Seeing these planes in the axial view, we went ahead with a neurosonography in the transvaginal method. So in this sagittal view in the transvaginal sonography, we could see and confirm the open fourth ventricle with the cisterna magna and an upward rotated vermis, which measured below the fifth centile. Going further, we could note partially formed corpus callosum. The genu and the anterior part of the body was visualized. However, the posterior part and the splenium could not be visualized at that time. There was also intraventricular synechian noted. On the parasagittal views, we could see subependymal hyperechogenic nodules, also adhesions intraventricular. The coronal views in the transcaudate view, we could see a cleft communicating, cystic cleft communicating the ventricular system with the subarachnoid space, suggestive of schizencephaly or porencephaly. And the posterior fossa in the cerebellar view, on the coronal view, we could see the posterior fossa cyst and the hypoplastic vermis. So all in all, we had multiple CNS findings and complicated that too. The rest of the growth scan was unremarkable. The growth was appropriate for the gestational age. The AFI was a bit increased, was about 22.8, which was more than 95th centile as per the charts for the current gestational age. The Dopplers were normal. So now we had this patient with all these multiple defects, and more so once the transvaginal neurosonography was done. The couple was quite understandably distressed. So we had a joint meeting with the obstetrician, the neonatologist, and the geneticist. And in light of these findings, we told them about potentially poor neurocognitive outcome that would be associated. We had a sensitive discussion regarding expectant management and late trimester MTP. The couple had flown in primarily because they were aware that the laws had been changed in India and could probably allow them late trimester MTP. So we accepted their desire for undergoing MTP and referred them to AIMS in view of late detection of multiple CNS defects. A fetal MRI was also sought. I've got a few images. Here in the first image, we can see in the transcerebellar plane, in the coronal view, the hypoplastic vermis. In the parasagittal view, we could see the cerebral attenuation, the ventricular synechiae, and over here, we could see bilateral porencephalic cyst. So I could see unilateral on the ultrasound, and the MRI helped clinch the diagnosis of bilateral. A possibility of vascular insult was also raised with this. So once the patient reached AIM, the repeat scan showed similar findings. The fetal MRI was also reviewed and showed bilateral porencephaly, and the diagnosis of fetal vascular insult was also kept. They underwent a genetic counseling promptly and were explained regarding the guarded prognosis and the need for further testing. Medical board was constituted swiftly for the patient, and after detailed counseling, the couple opted for undergoing a fetal blood sampling and caseal insertion at 35 weeks, 3 days. Subsequently, an induction of labor was done with mifepristone, and the couple was given a period of 2 days with that, but they could not undergo further dilatation. So they were given a rest for 2 days, and subsequently repeat induction with danoprostrone was also done. However, due to unsuccessful induction, they denied further doses, and they wanted to go for LSCS. A detailed counseling regarding the future fertility outcomes regarding repeat LSCS was also made, but one had to respect their wishes. So the mother gave birth to an LGA baby, about 3 kgs, male, and was macerated in appearance. The infantogram and external examination was unremarkable. The autopsy was deferred since the fetus was macerated. The placenta was sent for histopathology, which showed a placental infarct with increased intervillous fibrin deposition. The blood for CMV PCR was negative, and the thrombocyte count of the fetus was also normal. The fetal blood was otherwise sent for a whole exome sequencing. The reports are still pending as of today, and MSMLPA was sent for Beckford-Wiedemann in view of LGA fetus. Parental workup for thrombophilia has also been advised, not only because of the current history, but also in the past, she has history of previous preterm cesarean in view of severe preeclampsia. So all in all, it was a challenging case, and I remember the couple was very distressed when they came. You have real-time diagnosis of multiple intracranial defects, and unlike with cardiac system where we could still offer some level of surgery, with brain we are usually a miss. So it seemed like providing them with a dignified closure. So we had to proceed with the systematic evaluation and go ahead with their management. Late detection of anomalies in the third trimester always is challenging, and each growth scan brings forward an opportunity to evaluate the anatomy, which was very important in this case. Counseling in a sensitive way to deal with the grievance that the patient has, and managing their expectations is also very important. Referral pathways for timely intervention, keeping in mind the legal implications, are also something that we had to deal with this case. There were several obstetric challenges in the form of induction and the medical comorbidities in the form of chronic hypertension with superimposed preeclampsia, the gestational diabetes, all made this a very challenging case to manage. And at the end, the mode of delivery, everybody wanted for induction to proceed, but after a while, when the parents wanted to undergo elective LSCS, we had to respect their wishes. So just a little bit of a discussion of fetal vascular insults. So we could have either an ischemic or a hemorrhagic stroke. The common causes of ischemia can be maternal thrombotic conditions, preeclampsia, prolonged PPROM, chorioamnionitis, sepsis, autoimmune conditions such as autoimmune thrombocytopenia. We also have fetal conditions like inherited thrombophilia, gene mutations in the collagen 4A1 mutation, and congenital heart diseases. So all these things can lead to ischemic strokes. In fetal hemorrhage, there can be maternal trauma, use of anticoagulant therapy for various reasons, maternal infection, CMV, toxoplasma. For fetal, again, there can be thrombocytopenia. The commonest association is usually neonatal alloimmune thrombocytopenia. Sometimes with TTTS or after a procedure, we can have these kind of findings as well. But most of the times, we don't have an etiology that is usually detected. So a suggested workup for these kind of cases is usually to have a very good imaging to identify whether it was a hemorrhage or an ischemic stroke, and then provide both maternal and fetal workup. Thrombophilia workup in the form of inherited thrombophilia, latent 5, MHT, EFR, antithrombin 3, and also APLA testing is suggested. Looking at the fetal blood counts, we can get an idea if we can proceed with FNAIT workup. Usually when the thrombocyte count is less than 50,000, there is a more likely chance of having NAIT, which requires further workup in the form of HPA, human platelet antigen testing, and the maternal testing for antibodies against it as well. Toxoplasma CMV PCR was sent in this case as well and was unremarkable. Genetic testing is also required because there are certain genes, rarely so, called collagen 4A1, 4A2, which are associated with autosomal dominant porencephaly. So all in all, this case taught us the value of providing dignified closure to the couple, especially when they come across a very difficult diagnosis last at the very end. So I would like to thank everyone that was involved in this case, especially the maternal fetal medicine team at AIIMS. I would also like to thank the SFM for giving me the opportunity to present our case. And lastly, but not anyway the least, to Dr. Alok sir for providing his valuable time and insights while mentoring us throughout this time. Thank you so much.
Great, Dr. Ayush. Third trimester malformations not only call for a clinical dexterity, but also a sensitive approach to arranging the logistics. In this case, the maternal comorbidities added to the challenge, and you've been able to do it meticulously well. Congratulations. And now we move forward to our next speaker. She is Dr. Sarma Panchami Pradeep. Dr. Sarma, can you please share your slides?
Yes, ma'am.
So, Dr. Sarma is an alumnus of the Guwahati Medical College, pursuing a fellowship under Colonel Rima at the Amrita Institute currently. She takes us through a unique presentation of congenital cytomegalovirus infection, presenting as echogenic bowel with ascites, fetal anemia in the Welcome, Dr. Pradeep.
Thank you, ma'am, for that introduction. Good evening, everyone. I'm presenting a case on the paradox of protection as we report fetal anemia and fetal ascites in a diagnostic dilemma with cytomegalovirus infection in a pregnancy. So she was a 26-year-old woman, a second gravida with history of term macerated stillbirth, the cause of which was unknown to us at present. She conceived spontaneously with no history of consanguinity and no significant history. No other significant history. She presented to us at 30 weeks. She was referred in view of outside scan reporting fetal ascites and oligohydramnios. Her NTNB scan was normal. She didn't undergo any first trimester biochemical screening. However, her second trimester quadruple marker showed low risk. Also, anomaly scan reported normal. So reports available to us on the first visit. I'm so sorry. Somebody has asked me for, what's this one?
Nothing is fine.
I'm so sorry. Somebody asked me for some permission on this and I lost my screen for a second.
Absolutely no worries, Dr. Banjmi.
Yeah, I'm so sorry. I'm so sorry.
No worries. You're very much there.
Panchami, your screen is seen. You can just continue.
Okay, ma'am. Yes, ma'am. So the reports that we had on the first visit were all normal, and the blood group was A positive. What is that? I don't know. They were asking for.
Yeah. Can we have a full screen, please?
Yes, ma'am. I'm so sorry.
No worries.
So we scanned her at our center and we found fetal ascites and hepatomegaly. Then we had her. Ma'am, I'm so sorry. Is somebody asking for remote control of my computer?
You can simply carry on, my dear. There's no
Just
problem.
carry on.
Simply
Panchami,
carry
sir.
on. Don't
Just
Don't
carry
give
on.
any
click on
permission,
anything.
just carry on.
I'm not able to use my screen.
Click on the center of the screen, man.
Who is this? I don't know what is using. I'm
And
so
share
sorry.
and share it again.
Yes, I'll just start again. I am getting somebody asking for permission. I'm just. God, why is this happening?
You just
Stop,
continue,
share and share
Panchami.
again.
Yeah, share
Ma'am, my
again.
screen has frozen.
Okay, you
the
share
first-
again. Yeah.
Yes.
Just
Is it
share.
moving now? It's moving
Yeah.
now?
Yeah, just
I'm so
start.
sorry.
Yeah. Just
So,
continue.
yes, thank you. So I'm so sorry. We noted hepatomegaly and we also noted cardiomegaly and echogenic bowel. The mid-cerebral artery, PSV, was at 1.79 multiples of median, suggestive of fetal anemia. And in the background of ascites, along with hepatomegaly, FGR, and reduced LICA, this posed a dilemma. So since she had already crossed 30 weeks, we went ahead with cordocentesis for intrauterine transfusion, as any genetic test will take time, but fetal anemia needed to be corrected. So fetal blood was aspirated and sent for immediate hematocrit and CBC blood grouping. We sent for QF-PCR and whole exome sequence with copy number variations, and also PCR for parvovirus B19, CMV, and toxoplasma. We also sent sample for maternal torch serology, indirect Coombs test, and atypical antibody screening for minor antibodies. She also received antenatal steroids prior to the procedure. So we did the intrauterine transfusion. We proceeded with the IUT while awaiting the immediate hematocrit report, and the procedure was uneventful. Post IUT, we saw that the MCA PSV had decreased, and we received immediate results with pre-transfusion hemoglobin being 8 gram per deciliter, suggestive of severe anemia. Fetal blood grouping was A positive, direct Coombs test was negative, and platelet count was 54,000, suggestive of thrombocytopenia. Hematocrit was 24%. So we called her for a weekly follow-up. We received the maternal investigations. We had asked for a repeat ABO, which was A positive. Her indirect Coombs test was negative. The torch profile we had sent for was negative for IgM antibodies and positive for IgG antibodies towards rubella, herpes simplex virus, and cytomegalovirus. Also, she was negative for parvovirus IgG and IgM antibodies. So due to high clinical suspicion, we went ahead with avidity testing, which showed high IgG avidity for CMV. This suggested that although she is now immune, paradoxically it meant that the fetus may not have been, as it is highly likely that the infection either occurred in the first trimester or it was a secondary reactivation. So this is her parvovirus report, which was negative. However, the fetal cord blood was positive for cytomegalovirus DNA on real-time PCR. So with this positive PCR report, we dove into the diagnosis of congenital cytomegalovirus infection. So to ask ourselves, what does the review of literature tell us to look for on ultrasound? Usual fetal ultrasound findings of CMV in fetus would include ventriculomegaly, intracranial calcifications, hepatomegaly. Maybe there could be fetal ascites, splenomegaly, echogenic bowel, or placentomegaly. So out of these, we had 3 in our case, and this correlated our USG findings with the PCR report. So we followed her up and we wanted to check for signs of congenital CMV infection on follow-up. It showed us that post-IUT, the ascites had improved. The neurosonogram revealed no CNS stigmata of CMV, and MCA was stable, but we found further fall in the growth centiles with umbilical artery showing resistance to 97 centile. We suggested valacyclovir in the dose of 4 gram twice daily or 8 gram per day. However, the patient came to labor room 2 days after her follow-up scan with decreased fetal movements. The NST was pathological, so obstetrician had taken the decision to deliver via emergency cesarean section. A baby girl was delivered weighing 1.65 kg and she was admitted to the NICU for low birth weight, early preterm respiratory distress syndrome, as well as persistent pulmonary hypertension of newborn. Serology of the neonate sent on day 1 was positive for CMV IgM antibodies. And the investigations from immediate postnatal period showed hemoglobin of 12.9 and platelet of 110,000 and a hematocrit of 44.1%. Also, there were signs of infection with lymphocytosis, neutropenia, and leukocytosis as well. So genetic testing reports that we had received by then had come out to be normal. The baby was started on ganciclovir, later switched to valganciclovir, which will be continued for 6 months. Auditory and visual testing for the moment is normal. Head scan done at birth was normal, and there was no cytomegalovirus insult noted. So the BERA testing is planned at 2 months of age. Baby won the battle against persistent pulmonary hypertension of newborn after 7 days. Why this could be noteworthy even from the standpoint of pediatrics is because this is a rarely reported association and it is usually responsive after 35 weeks, responsive to treatment. But here our 33-week-old star has won with the efforts of the excellent neonatology team. She was given inhaled nitric oxide, surfactants, sildenafil, and was even ventilated. So this is an article which has described that it is important to screen for congenital cytomegalovirus in such cases with lung involvement because even though it is scarcely reported, it can be a possibility. So what were the challenges in this case? She presented to us at an advanced gestation. We found severe fetal anemia in an Rh positive mother who was ICT negative. And there was fetal ascites, there was hepatomegaly, there was thrombocytopenia, there was growth restriction, and there was decreased LICA. So CMV IgG positive serology, as well as high IgG avidity, it would suggest immunity, but we did find certain suspicious infective signs which would warrant diagnostic testing of the fetus via invasive methods. And diagnosis was a challenge as this high avidity could mean primary first trimester infection or even a secondary reactivation. So how do we prognosticate the pregnancy of this infected fetus? When we talk about prognostic markers, it will depend on the gestational age at the moment of maternal infection. So poorer prognosis if it is infected in earlier gestations. And if there are ultrasound or MRI anomalies noted, it will be a poorer prognosis. Viral load in amniotic fluid, although it was not done in our case, if it is very high, it gives a poorer prognosis. And viral load would also cause fetal changes like thrombocytopenia. So thrombocytopenia will indicate a worse prognosis. In our case, the CNS lesions were not there, so we are expecting a good prognosis, and the negative predictive value of this would be 95 to 97%. Poor prognosis happens when there are severe lesions which are inclusive of the CNS lesions. So many case reports have now unveiled the challenges in diagnosing congenital CMV infection. And there are also now case reports of fetal anemia in the presence of cytomegalovirus in the fetus. Why this is noted? Because in one such case, 3 cases with similar ultrasound findings and fetal anemia showed that all 3 were positive for CMV DNA on PCR. 2 of them were given intrauterine transfusion, one of them carried to 34 weeks with hardly any sequelae. This goes to show that in the presence of severe fetal anemia, congenital cytomegalovirus should always be considered as a possible cause. Screening test and a correct diagnosis of primary infection would be of paramount importance, but even non-primary infection can cause severe anemia in the fetus. So to wrap up the case, I would like to reiterate even few signs of congenital cytomegalovirus infection on the ultrasound would prompt to look for TORCH serology, and in the presence of IgG antibodies or IgG positive status, regardless of IgM, we should offer amniocentesis for cytomegalovirus PCR and molecular chromosome testing, as there is high risk of congenital CMV. There is also now literature to support valacyclovir to be given, especially in the first trimester, in the dose of 8 gram per day, which is beneficial to prevent the vertical transmission. There is also a consensus recommendation which has been released, which includes screening the mother for cytomegalovirus in the first trimester, oral valacyclovir administration, and timely amniocentesis for diagnosis. An update as recent as September again suggests universal screening may become an important tool in detection of congenital cytomegalovirus. So the lessons learned here is any fetus with MCA PSV of more than 1.5 multiples of median will benefit with intrauterine transfusion even if there is intrauterine infection. IgG positive status with high avidity at a later gestation, like in our case, would suggest first trimester infection, or it could be secondary reactivation. Screening for cytomegalovirus in pregnancy could be a good tool because it is the most common infection worldwide, with primary infection rates of 1 to 4% and vertical transmission being as common as 1 in 3 babies. Valacyclovir to be given in 8 gram per day in the first trimester in screen positive cases to prevent vertical transmission. So had she been screened in the first trimester, we would have been able to diagnose and offer her this prevention. So thank you all for listening, and to SFM Delhi chapter for this forum to exchange these beautiful cases, and special thanks to my mentor, Reema Bhatt ma'am, for being the most wonderful guide. Thank you.
Great, Dr. Panchami. A typical history of fetal intrauterine infections is seldom elicited clinically, and a high index of suspicion is required for diagnosis, especially when the patient presents in third trimester, where serology is not going to be helpful. Very insightful to suggest that fetal anemia could be a presentation for congenital CMV. Great job. Thank you so very much. So now another illustrious young gun from the Amrita Institute, Dr. Namrata, talks about fetal chylothorax, where thoracoamniotic shunt placement has helped resolution of the chylothorax and salvage the fetus. Dr. Namrata, we invite you to share your slides, please.
Thank you, ma'am. Yes. Yes, somebody find. Good evening, everyone. Warm regards from Amrita Hospital, Faridabad. My case presentation for today is thoracoamniotic shunting in congenital chylothorax, a journey from diagnosis to recovery. My patient is 32 years, primary gravida. She came to us at 18 weeks, 5 days of gestation. She was referred to us in view of mild pleural effusion in the right thoracic cavity in the fetus. Her combined first trimester screening was low risk. Her blood group was O positive. We did her scan at 18 weeks, 5 days at our own center, and pleural effusion was more on the right side as compared to the left. The couple was counseled regarding the causes of pleural effusion and the need for invasive testing. Breast cardiac structure survey was done, which was normal. There was no ascites, no dysplasias. Maternal workup was done and ICT was negative. MCA PSV was normal, hence it rules out fetal anemia, and mother was immune to TORCH infections. So amniocentesis was done and the sample was sent for QF-PCR and whole exome sequencing, which came out to be normal. We called the patient after 4 weeks. At 21 weeks, 5 days, there was no significant change in the ultrasound findings. Then we called the patient after 4 weeks follow-up, but she was lost to follow-up and then presented to us at 28 weeks, 6 days with massive pleural effusion, along with significant mediastinal and heart compression. There was flattened diaphragm, which was indenting the liver. And on coming to the skin, there was extensive subcutaneous edema. So due to this passive pressure, there was development of atelectasis. Hence, these findings were suggestive of non-immune fetal hydrops with bilateral pleural effusion, which was more on the right side as compared to the left. Along with mild ventriculomegaly and polyhydramnios. As there were no genetic association, there was high suspicion of chylothorax. So we counseled the couple regarding the need for thoracocentesis to establish the diagnosis along with amniodrainage. So thoracocentesis was done, and the needle was inserted through fifth intercostal space by posterior approach, and the sample was sent for cytology. This caused temporary decompression with improvement in fetal heart rate and movements. Amniodrainage was done, and around 1500 ml of clear fluid was drained. Now, on the basis of cytology, there was increased lymphocytes. The lymphocyte count was more than 80%, and the clinical findings and the exclusion of other secondary causes, we made the diagnosis of chylothorax and counseled the patient accordingly. After 3 days of thoracocentesis, that is around 29 weeks, 4 days, there was reaccumulation of effusion and there was persistent hydrops. So we made a decision of thoracoamniotic shunt placement. Now the real challenge was thoracoamniotic shunt. Basically, it's a double pictal catheter which is inserted, and the one end is inserted into the fetal thoracic cavity and the other end is in the amniotic cavity. It helps to drain the persistent pleural fluid into the amniotic cavity, allowing the fetal lungs to re-expand and prevent complications such as pulmonary hypoplasia or hydrops fetalis. Antenatal steroid was covered before the procedure. This is how pictal catheter is loaded with the help of a guide wire and a plunger. It is flexible and has recoiling property. This video demonstrates the insertion of thoracoamniotic shunt into the fetal thorax. As you can see in the video, the needle is passed through the fifth intercostal space into the fetal thorax. Now, on one end, this end was secured in fetal thoracic cavity. This is the thoracic end of the shunt. While the other end was secured through the skin of the fetus in the amniotic cavity. As we can see in the video, this is the shunt placement in the amniotic cavity. This is the 3D reconstruction of the thoracoamniotic shunt. So after 3 days, we checked the shunt placement and hydrops has started showing resolution. The pleural effusion has not redeveloped. So after 5 days of procedure, at around 30 weeks, she developed preterm labor, for which tocolysis was started, neuroprotection was given. She delivered a male baby by cesarean sections, and on intra-op, there was some retroplacental clots, could be abruption, weighing 1.8 kgs. The extreme important point here is that the antenatal shunt was immediately clamped post-delivery, and baby was put on ventilation and new chest drainage was inserted. Pleural fluid analysis was done postnatally, which showed lymphocytic predominance of around 95%, and there were low triglyceride levels initially, which later rose to 251 mg per dl post-feeding with medium chain triglycerides. So baby was managed with medium chain triglyceride-based formula and octreotide infusion, which was initially started and then gradually tapered as the drainage reduced. Then the octreotide was discontinued after 7 days because baby was starting to develop abdominal distension. There was transient persistent pulmonary hypertension of newborn, and shock was managed by using inotropes, and it was resolved within 48 hours. The baby was gradually weaned from high-frequency oscillatory ventilation to continuous positive airway pressure, and then to humidified high-flow nasal cannula, and was finally maintained on room air by day 31. HRCT was done, and chest initially showed ground glass opacities with mild effusion, while significant improvement on the repeated scans was seen. Bronchoscopy was done, and it revealed temporary bronchial obstruction, which was managed conservatively with chest physiotherapy. So, baby maintained saturation on room air. Baby was tolerating oral feeds. Vitals are stable, and there was normal urine and stool output. So final diagnosis of bilateral congenital chylothorax with secondary pneumothorax with transient persistent pulmonary hypertension of newborn and medically managed necrotizing enterocolitis was made, and baby was recovered well with conservative and supportive therapy. Baby was discharged on 32 days of life, and baby weight at the time of discharge was 2700 grams. So basically, now coming to fetal hydrothorax, basically fetal hydrothorax can be bilateral, unilateral, or generalized. Its incidence in newborn is around 2.2 to 5.5 per 1,000 births with male predominance. Primary hydrothorax, it can be divided into primary hydrothorax and secondary hydrothorax. Primary hydrothorax is also known as congenital chylothorax, and it is a diagnosis of exclusion where all genetic and malformation causes are excluded. While secondary causes can be associated with chromosomal abnormalities like trisomy 21, monosomy X, rhazopathies, Turner syndromes, other causes can be thoracic masses, infections like parvovirus and CMVs, and metabolic or hematological disorders. Pathophysiology of fetal chylothorax formation is basically there is lymphatic malformation which causes lymph flow obstruction. This due to the obstruction, there is rupture of thoracic ducts which causes accumulation of chylous effusion. And this causes impaired venous or lymphatic drainage, which promotes pleural effusion formation. And then there is accumulation of chyle, which may lead to fetal hydrops, and in unfortunate cases, it can even cause death. So the importance of thoracoamniotic shunting is that due to the continuous drainage of pleural fluid, this causes decompression of fetal thorax and led the lungs to re-expand and grow, and hence prevent armored chest and improve postnatal ventilation. Octreotide, role of octreotide in chylothorax, basically it's a somatostatin analog. It decreases lymphatic flow and triglyceride reabsorption and hence reduces chyle formation, and can be usually used up to 5 to 10 days. Medium chain triglyceride based formula, its aims in reducing lymphatic flow and chyle formation, and can be continued for 4 to 6 weeks or until the effusion resolves. This is our fighter who survived congenital chylothorax. Other methods include surgical methods like thoracic duct ligation and pleurodesis. They have a definitive control of leak. The overall prognosis is around 60 to 80% in isolated cases. Better outcomes occurs in isolated unilateral or small effusion cases, while poor prognosis is there in patients who are having hydrop fetalis, chromosomal or syndromic associations, or prematurity. Long-term issues are rare, but can have recurrent effusions or nutritional deficiencies. Multiple case studies have been done which reported use of thoracoamniotic shunting with a good survival rate when postnatally used with medium chain triglycerides and octreotides. Another case study showed use of exit procedures for airway stabilization in severe hydrops. So take-home messages, routine anomaly scans can detect subtle effusions and prompt early referral. Comprehensive workup like genetic testing, infection screen, and Doppler is essential to exclude secondary causes. Parents must be counseled regarding prognosis and intervention options. Invasive testing provides definite diagnosis with minimal risks. Prenatal interventions like thoracocentesis, thoracoamniotic shunting relieves the intrathoracic pressure and may reverses hydrops. Most important is early diagnosis and multidisciplinary care, which significantly improves survival. Postnatal management with ventilation, drainage, medium chain triglyceride diet, and octreotide can lead to complete recovery. Isolated cases have favorable outcome. Survival improves when hydrops resolves before birth. Thank you everyone, and special thanks to Dr. Ashok Khurana sir, Dr. Alok Vashne sir, and all the SFM team for this great opportunity. My sincere thanks to my mentor, Dr. Reema Bhatt ma'am, whose support and encouragement have been the pillar of this work, and for giving us this opportunity. Thank you.
Very well presented, Dr. Namrata. Congratulations. Chylothorax that keeps refilling is a challenging problem, and you've managed it beautifully well. A good perinatal outcome is very encouraging. I can see a lot of people. Welcome back, everyone. I invite Dr. Saloni Kamboj to share her slides, please. So our next promising young gun tonight, Dr. Saloni Kamboj, is ex-faculty and current fellow at the All India Institute of Medical Sciences, New Delhi, with an impressive array of awards to her credit. She presents tonight a case of macrocystic CPAM, which resolved with thoracocentesis and resulted in an excellent perinatal outcome. Welcome, Dr. Saloni.
Thank you, ma'am, for such a kind introduction. First of all, I would like to thank Delhi chapter SFM, the entire team for providing me this opportunity. Are my slides visible?
Yes, please.
Yeah, thank you. So to begin with, at what point does a cystic lung lesion on an ultrasound stop being just an image and becomes a call for action? So let's navigate this through our case. My patient was a 26-year-old female, primigravida, PCOS, ovulation induction conception. She was a known case of controlled hypothyroidism. Her combined first trimester screening was within normal limit. However, on her anomaly scan done at 22 weeks, there was a macrocystic CPAM seen of a size 3.8 into 2.6 into 2.8 centimeter with no hydrops. However, mediastinal shift was seen. The rest, no gross congenital anomaly was seen, as we can see the other images of her anatomy scan. So how do we proceed when we see any thoracic anomaly? We see whether it is a lateral anomaly or a median anomaly, or the echogenicity is hypoechoic or anechoic versus hyperechoic, or whether it is bilateral or unilateral. So how to differentiate? If it is a unilateral anomaly, hypoechoic in nature, we think more towards cystic CPAMs or hydrothorax. If it is a hyperechoic lesion, we think of the solid CPAMs, sequestration, CDH, or tumors. If it is a bilateral anomaly, hypoechoic, we feel that it is bilateral hydrothorax. If it is an hyperechoic anomaly, we think more towards chaos. If it is a median anomaly, hypoechoic, it's a Bosch-Delac CDH type of hernia or absent pulmonary valve syndrome. Or if it is a hyperechoic lesion, we think of chest tumors. So there are 5 questions when we see a thoracic anomaly. How do we proceed? Related to CPAM. Do the lung occupy all the thorax? Yes. Is the parenchyma homogeneous in the thorax? No. Is there a centered heart? No. Is there a normal diaphragm morphology? Yes. Is the tracheobronchial tree normal? Yes. So diagnosis was either limited to CPAM or bronchopulmonary sequestration. So how do we differentiate between the two? So BPS is a lung sequestration, which is characteristically more solid, has a supply from the aorta, more predominantly in the inferior lobes of lung. CPAM is the more cystic nature, has the supply from the pulmonary vessels, could be anywhere in the lungs. So diagnosis was more towards CPAM. So what are actually CPAMs? They are the hematomatous lesions which can comprised of cystic or adenomatous elements. They can arise from trachea, bronchiolar or alveolar tissue, giving rise to various types of CPAMs, type 1, 2, 3, 4. So basically we divide the prenatal CPAMs into the macrocystic, microcystic, or they can be mixed lesions also. So macrocystics are the one who have more of anechoic components, more than 5 mm, and microcystics are less than 5 mm. So these are the various videos showing. The first one is the macrocystic CPAM. The second one is the microcystic. We can see the characteristically small cysts in the one part of the lung. And third one is the mixed type of CPAM, which has a macrocystic and a solid component also. So why are we so worried about the CPAMs? What are the consequences that it can have? It can lead to a mediastinal shift, esophageal compression, small stomach, polyhydramnios. There can be ipsilateral diaphragm flattening, which ultimately can lead to compression of heart and can lead to hydrops fetalis. So how do we evaluate CPAMs? First of all, we have to take the quantitative measurements. We have to think about the adjunctive imaging. We have to assess if there are any associated anomalies and further assessment of those anomalies. So the basic CVR, in which we take the height, anterior-posterior diameter, transverse diameter of the lesion divided by the head circumference, take the volume divided by the head circumference. Why the CVR is important? Because the cutoff of 1.6 at presentation appears to distinguish fetus, which will more likely develop the hydrops. So there are new markers also. We can calculate the mass to thoracic ratio, which is taken in an axial section, in which we calculate the ratio between the transverse diameter of the mass by the transverse diameter of the thorax. When we think about the adjunctive imaging, we think about the color Doppler to see the supply from the pulmonary vessels. We think about the echo to see the cardiovascular profile scoring to help and plan the predict fetal outcomes. MRI is rarely needed when it is needed, when the diagnosis is uncertain, when we suspect the bilateral lesions. It is done basically to delineate abnormal and normal anatomy when the entire lung is involved by the mass. Luckily, we did not require any MRI in our case. So 6 questions, the basic 6 questions when we see any anomaly. Is it lethal? Are there associated anomalies? Is genetic evaluation required? How to prognosticate parents? Follow-up of such lesions, place and mode of delivery. So let's see one by one. So is it lethal? No, CPAMs are not associated with any lethal condition. Are these associated anomalies? There can be 10%, but luckily they were ruled out in our case. Is genetic evaluation required? Historically, it was not required for isolated CPAMs. It was recommended with if additional anomalies are there. But there have been recent developments which have found the possible links between the CPAMs and certain genetic mutations in the genes related to lung developments, such as FGFR2, DICER1, KRAS gene, and TP53 gene. So recently, there has been a change and trend to offer the genetic evaluation to such patients. So we also offered the same, but it was denied by the couple. So how do we prognosticate such fetuses and such parents? So we counsel that the rapid CPAM growth takes place about 20 to 26 weeks, which peaks at 25 weeks, but then goes into plateau phase or regression phase. 50% of them persist till delivery, 15% of them decrease in the size, and 50% of them appear resolved on the ultrasound before delivery. This appears to be an important counseling point because when the patient came to us, she was very insistent on MTP, and we counseled her that you have to continue. It is a surgically correctable condition. You will continue the pregnancy. Otherwise, we also counsel if it is a macrocystic CPAM, there are more chances of postnatal symptoms, but surgically correctable. So this is the patient information leaflet that we use at our institute to counsel such patients. We also tell them about the poor prognostic markers, that is the presence of high drops. If the CVR is more than 1.6, the mass to thoracic ratio is more than 0.251, and there is increased cardiomediastinal shift angle, which predicts the adverse perinatal outcomes and high drops. So when she was followed up at 24 weeks, there was presence of high drops, and there was increase in the CVR ratio, which was more than 1.6, and we could see the macrocyst component increased. So how do we manage such hydropic fetuses? If the fetus is more than 32 to 34, we plan an early delivery with immediate postnatal resection. But what if the fetus is between 20 to 32 weeks? So we have to intervene with the goal of improving the fetal hemodynamics and to prevent the lung hypoplasia. So how did we intervene? So we planned an thoracocentesis in view of increased CVR, and because the fetus was developing high drops, you can see the video in which we did a thoracocentesis, placed the needle into the macrocystic component, and took out about the 30 to 40 ml of fluid, and we can see that it is collapsing nicely after the thoracocentesis. So these are the post-intervention pictures in which the CPAM remained stable after one thoracocentesis. We procured a shunt also with much difficulty from US. However, it was not used, but we planned if the cyst refills again, we would have put a shunt, but luckily she did not require. The CPAM remained stable. She had an elective LSCS at 37 plus 4 weeks in view of breech with stage 1 FGR with a birth weight of 2.4 kg. The APGAR was fine. Baby had mild respiratory distress with a Silverman Angel score of 2, put on CPAP. So these are the postnatal pictures, X-rays and CT suggestive of type 1 right lower lobe CPAM. Because the baby was symptomatic, was requiring CPAP, although on a minimal support. So the baby was planned for advanced thoracic imaging, that is CT, and was handed over to pediatric surgery team from the neonatal ICU for an early surgical resection. Because the timing of the surgery, if the baby is asymptomatic, the surgery is deferred in the neonatal period. We have to wait for the sufficient size of the lung so that we can go for a thoracoscopy. So the ideal time to operate is 1 month to 4 years, preferably at 6 months of age. But since the baby was symptomatic, so early resection helps in a better compensatory lung growth. So the baby was planned on a thoracoscopic right lower lobectomy on postnatal day 10. This is the video of the surgery.
Right thoracoscopy was done, and we can see the lesion in the lower lobe, which is then decompressed with the vessel sealer. We can see the upper lobe which was normal. Then pulmonary ligament is dissected to rule out a systemic supply. Now we are in the oblique fissure, dissecting the pulmonary artery. Here we can see the branches, most probably the basilar artery, which was then dissected. This is the branch with the superior segment, which was taken control of, followed by control of the basilar artery. So now the arterial supply is gone. We shift our focus to the anterior pulmonary ligament, where we can see the anterior pulmonary vein taking control of one of the tributaries right now, which was then divided. Now we're taking control of the pulmonary vein, and this is the bronchus that we have hooked. And it is clipped. And once we divide it, the specimen is out.
So this is the surgical specimen, the CPAM tissue that was taken out, and you can see how beautifully the lungs have expanded on day 14, maybe was discharged on day 14 with absolutely stable mother side on room air. So what are the learning points that we learned from this case? An accurate prenatal diagnosis, counseling of such patients, how to carefully monitor, timely referral to appropriate center, need for timely surgical intervention, and such masses should be delivered in a tertiary care center with the pediatric surgery backup. So I would like to thank my department of neonatology, pediatric surgery, my radio diagnosis, medical social worker who helped to procure shunt. Thank you so much.
Dr. Kamboj, if you were to read the chat box, you would be truly marveled today. This is one of the best days. Vital questions and very pertinent answers and an extremely crisp presentation. And I must say the thoracoscopy video was truly very, very insightful. I can still see people sending you much accolades, and that's really wonderful and very, very heartwarming. Thank you so very much, my dear. Thank you. The next promising young gun today, after Dr. Saloni Kamboj, is Dr. Alina Khan. Can I please invite her to share her slides? So Dr. Alina Khan is here to present her case of a humongous abdominal mass in the third trimester after an absolutely unremarkable second trimester scan. Dr. Khan is pursuing her fellowship in maternal fetal medicine at VMMC and Safdarjung Hospital. Very welcome, Dr. Khan. All yours.
Good evening, everyone. I'm Dr. Alina, and today we'll be talking about prenatal diagnosis of a fetal abdominal mass appearing in late third trimester. Late presenting fetal abdominal masses can transform an otherwise uneventful pregnancy into a diagnostic and management challenge. A new mass after a normal mid-trimester scan calls for prompt evaluation, precise diagnosis, and coordinated action. This case highlights how integrated imaging and teamwork can turn a complex prenatal diagnosis into a well-managed neonatal outcome. There was a 32-year-old Gravida 3 Para 2 Live 2 who came to us at 36 weeks of pregnancy with the growth scan that was suggestive of a large fetal abdominal mass. Her first trimester and second trimester anomaly scans were normal. There was no serum screening available. A priori risk was 1 in 620, and on current scan there was a solid cystic lesion abutting the right kidney along with moderate ascites. On scan, there was a 5 into 6 into 5 centimeter mixed echogenic lesion. Doppler suggested there was an internal vascularity. Ascites was present, but no hydrops. Mass was mainly on the right side of the abdomen. No element of FGR. Effective fetal weight was 2.75 kg. Umbilical artery PI was normal. MCA PSV was normal. There were no other sign of hydrops. As you can see, there is a mass with solid component, mixed echogenicity, and multiple cysts, along with the ascites. The right kidney appears to be enlarged, left kidney appeared to be normal. Blood supply seemed to be arising from the aorta, and there was vascularity within the mass also. So coming to differential diagnosis, germ cell tumor could be one of the diagnoses. They're large, mixed, solid cystic lesion, as was in our case, may have calcification or fat and can displace kidney, causing ascites and hydrops sometimes. Adrenal tumor can be other differential diagnosis. Their right adrenal masses are more common, as ours was also a right side mass. They can be solid or cystic. They can compress kidney. Mesoblastic nephroma, again, they can be intrarenal mass, we could not delineate the origin of the mass, whether it was coming from the kidney or above the kidney. So this was kept in differential diagnosis. Wilms tumor generally appear postnatally, so it could be a less likely diagnosis. The rest of the abdominal masses are generally cystic and thin, with thin septa and mixed. They generally do not have mixed echogenicity. So our diagnosis was singed at renal mass, suprarenal mass, or some other retroperitoneal mass that was just abutting the kidney. So coming to the next step, an MRI was done. It confirmed that there was a retroperitoneal solid cystic mass. It was displacing the kidney, but it was definitely not invading the kidney. As you can see, it's a huge mass with nodules in septa, mixed echogenicity. Same can be seen on the sagittal section. Mass and the kidney appear to be separate. So now what? It was discussed in a multidisciplinary board along with obstetrician, radiologist, neonatologist, and pediatric surgeons. Parents were counseled accordingly. Since it was already 37 weeks, a decision of postnatal evaluation and surgery was taken. Patient was planned for elective cesarean section at 39 weeks in view of previous to cesarean section, with pediatric surgery team on standby. At term gestation, 39 weeks, the patient underwent an elective cesarean section. A female baby of 3 kg was delivered without any immediate cardiorespiratory compromise. On physical examination, a grossly distended abdomen could be seen due to the tumor mass. The neonate remained, as you can see, on the scan, there is a huge mass with internal vascularity. A CT scan was done. On CT scan, a large, well-defined, heterogeneously enhancing abdominal pelvic lesion was seen. Epicenter seemed to be a right suprarenal region, not invading the kidney or the suprarenal gland, containing fat, soft tissue, and bony elements, displacing the right kidney posterior inferiorly and bowel loops to left side, and distorting the whole of the abdomen. Differential diagnosis of mature teratoma along with fetus in fetu was kept. The baby was posted for laparotomy at 10 days of life. Intraoperatively, a large mass with 80% solid lesion was seen. The vascularity seemed to be arising from the major vessels and was separate from kidneys and ovaries. This is the mass intraoperatively. These are the feeder vessels that have been tied, and the mass after removal. Mass was sent for histopathology. On gross specimen, it was a unilocular cyst filled with sebaceous material and hair. On microscopy, mature elements of cartilage, bone, epidermis, and fat and pancreas were seen. On cytology, there was no malignant cell, so diagnosis was mature teratoma, germ cell tumor. So this case exemplifies several important clinical principles. First of all, a normal second trimester scan does not preclude that an anomaly cannot develop later on. The interval appearance of this substantial mass between the 20-week scan and the 36-week scan highlight that this mass was an aggressively growing tumor. The case reinforced that the value of third trimester surveillance, particularly when clinically indicated. Complementary role of ultrasound and MRI has been explained. Multimodal approach is required in such cases. On review of literature, it was seen that these masses have fetal tumors have an incidence of 1 in 1500 to 1 in 3000. Germ cell tumor account for less than 5% of these masses, and retroperitoneal germ cell tumors far fewer than other germ cell tumors, 5% of all the germ cell tumor. MRI helps in reclassifying ultrasound lesions in about 25% cases. They generally have a good outcome, about 90 to 95% of survival. Poor outcome is associated with when there are malignancies or there is hydrops. So MRI along with Doppler is helpful. So coming to germ cell tumors, how do they develop? They are rare congenital neoplasm, and germ cell tumors are what do they happen when the ovaries are developing, the yolks from the yolk sac, these germ cells are traveling. So within the within the aberrant migration, these primordial germ cells can get stopped anywhere in this path, or they can travel caudally or cranially, causing germ cell teratoma in various locations such as sacrococcygeal teratoma, retroperitoneal teratomas, as in was in our case, mediastinal masses, cervical, and sometimes intracranial masses too. And they can mimic renal or hepatic lesions. Ultrasound is the first line of diagnosis, and MRI refines the location. On ultrasound, we see a solid or mixed solid cystic mass with internal vascularity. And MRI help. On MRI, there is a heterogeneous T2 signal with restricted diffusion, and about 90% of diagnosis is made on MRI. Outcome is good in 85 to 95% of survival. Poor outcome is associated in hydrops, less than 25% chances of survival. Rapid growth, incomplete resection, or malignancies has only 40 to 45% of survival. So to conclude, fetal abdominal mass presenting in late gestation can pose significant diagnostic and management challenge. So if a mass appears, what to do next? These masses generally appear between in third trimester only, from between 28 weeks to 36 weeks. So, and since they are rapidly growing, a repeat scan is necessary. Involvement of multidisciplinary team on the standby is necessary to discuss how you will proceed with the case. Second, every 2 weekly scan is necessary to see how this mass is growing and if any hydrops is developing. So even if you have a mid-trimester reassuring scan, you should maintain your vigilance throughout the pregnancy. These are my references. Thank you.
Thank you so much, Dr. Khan. The Young Guns webinar Delhi chapter can prove to be a ready reckoner for fetal intra-abdominal masses, with cases ranging from urethral diverticulae to extra-ovarian GCTs being discussed intricately, along with their differential diagnosis. Commendable, Dr. Khan. Thank you once again. We now invite Dr. P. Soumya Singh to please share her slides. Dr. Soumya Singh, our last speaker tonight, is Fellow Maternal Fetal Medicine from the Maulana Azad Medical College, New Delhi. And she also has to her credit a fellowship in advanced obstetric imaging from Pune. Currently a consultant at Cloud9 Hospital, she discusses the presentation and follow-up of a case of persistent cloaca. All the very best, Dr. Soumya. Welcome.
Thank you for the kind introduction, madam. So are my slides visible?
Yes.
Yeah. So good evening, everyone. I'll be presenting a case of persistent cloaca here. So Mrs. X, 23-year-old, primigravida with spontaneous conception. She was referred to our OPD at 24 weeks in view of a fetal intra-abdominal cyst. Her past history and family history were not contributory. Coming to her pregnancy history, she was booked at a dispensary. She was not having any history of fever, rash, or any exposure to any teratogenic drug. Folic acid supplementation was adequate. All other antenatal investigations were normal. She had only one scan done in first trimester, which was an early scan of 6 weeks where cardiac activity was demonstrated. Her first trimester screening was missed, so there was no NT scan or double marker. In second trimester, the targeted anomaly scan was done outside at 22 weeks, and it was suggestive of anhydramnios with a fetal intra-abdominal cyst. With this report, she came to us when she was examined, and it was found that the fundal height is slightly more compared to period of gestation. Her routine antenatal investigations were normal. Then a fetal USG was done. On ultrasound, there was no liquor. There was gross fetal ascites. Large anechoic cystic lesion was present of 13 into 9 centimeter, which was predominantly in the abdominopelvic region. There was right hydronephrosis. Left renal agenesis was there. Target sign could not be seen, and also a separate bladder could not be demonstrated. So this is how a normal perianal muscular complex looks. So this is the target sign. But in this patient, we were having an absent target sign. So our differentials were cloacal abnormality. That was first due to anal atresia and a huge cystic mass. So, or a female genital tract dilatation. Also, our second differential was megacystis because the cyst was large with slight outpouching and was without septations, and also a separate bladder could not be visualized. Our third differential was ovarian cyst, but that was least likely because it generally presents in the third trimester. And in our case, it was right in second trimester, maybe before that, because the patient missed her NT scan. So we went to do an MRI. So on MRI, there was gross fetal ascites, and also a large well-defined cystic lesion was seen, which was predominantly in the pelvis. The cyst was hypointense on the T1 weighted sequence and hypointense on the T1 weighted sequence, and it was hyperintense on the T2 weight sequence. Again, there was right kidney was hydronephrotic, right ureters were dilated, and left kidney was absent. And on T1 sequence, we could see a hyper-intense meconium signal seen, and something was which was attaching to the cyst. There were bilateral hypoplastic lungs, and again on T2 sequence, we could see something hypointense was attaching to the cyst. The spine was reported as normal. This attachment could have been sigmoid colon. This was our antenatal diagnosis, or some part of the colon. So our provisional diagnosis at that time was cloacal abnormality with pulmonary hypoplasia, with unilateral renal agenesis, with anhydramnios, with query urinary ascites. We thought that the ascites that we are seeing is maybe urinary, because in most of the cloacal abnormalities, we know that the ascites is basically due to the urine that comes out from the fallopian tube. So we did the prognostic counseling. The couple was told that this baby has a guarded prognosis in view of multiple congenital anomalies, including the hypoplastic lungs at a very early age. They were offered MTP after a medical board approval, but the couple wanted to continue. Also, as per the MRI findings of suspicious urinary ascites, we thought to proceed with an amniocentesis to confirm the urinary ascites. But to our surprise, both the fluids were different. The amniocentesis in the cystic tab that was done at 24 weeks. So the yellow one is the ascitic fluid and the white one is the cystic fluid. So the possibility of urinary ascites the urine coming from the fallopian tube was ruled out. And also, then the second thing that came to our mind was an obstructive uropathy leading to the urinary ascites due to the transudation of fluid into the peritoneal cavity. Then coming to the clinical course, at 29 weeks period of gestation, the patient came to emergency with complaint of pain abdomen. Again, the size of uterus was much increased compared to the as per the period of gestation. It was tense. The symphysiofundal height was 33 centimeter and heart rate was there. And the patient was going in labor. So a fetal ascitic tap was done to facilitate vaginal delivery in view of guarded prognosis. A stillborn was delivered vaginally with ambiguous genitalia. And the general examination of the baby revealed a normal face, grossly distended abdomen, a small perineal opening below the phallus-like structures, and an imperforate anus. So we proceeded with the fetal autopsy. On autopsy, we saw a huge cyst and a uricus that was suspending the cyst. Also, we could see that there was, when the cyst was cut open, the urogenital septum and the rectovaginal septum were not formed. Also, there was a very small opening below the phallus-like structure and an imperforate anus was there, which was possibly anal atresia and vaginal atresia. Also, we could see right hydronephrotic kidney and a dilated ureter. And on the left side, there was an empty renal fossa. Also, this the structure that we were seeing in the MRI was seen as a sigmoid colon that was opening on the posterior surface of the cloaca. Also, on fetal autopsy, so we kind of confirmed our findings of ultrasound and MRI on the autopsy that was of abnormal cloacal septation, imperforate anus, sigmoid colon opening in the posterior part of the cloacal cyst. Gonads were seen, but they were atretic. A separate bladder, uterus, fallopian tube were not seen. And a single right hydronephrotic kidney was seen. So coming to the embryology, right in very early embryological stage, in 4th week of development, the embryo folds the embryo folds to form an cranial end and the tail end. In the cranial end, we can see the buccopharyngeal membrane covers the yolk sac, and yolk sac will be leading to formation of the gut tube. The gut tube is again divided into foregut, midgut, and hindgut, and the hindgut portion of the gut tube gives rise to allantois, and the other extension is vitalointestinal duct. This allantois will be forming future urachus. Then what is cloaca? Cloaca is actually the terminal part of the hindgut, which is just below the allantoic diverticulum. And from this allantoic diverticulum, urorectal septum develops, which divides the cloaca into 2 parts, that is urogenital sinus and the primitive rectum. The primitive rectum then forms the rectum and the anal canal, and the urogenital sinus forms the vagina and the urethra. So in this case, what we could see that urogenital septum and the urorectal septum both are not formed. That's why the cloaca is intact, undivided. Also, the division of these septum lead to normal perineal orifices, that is urethral, vaginal, and anal. So as we talk of the cloacal abnormalities, so they can be a less severe spectrum and a more severe spectrum. In the less severe spectrum, the urorectal septum is developed, but the urogenital septum fails to develop, and this spectrum includes urogenital sinus, cloacal variant, and the posterior cloaca variant. Also, in the more severe variant, urorectal septum fails to develop. Also, the urogenital septum fails to develop. So we will mostly be seeing one single opening. That was in our case. So our case was falling in this spectrum, which was of severe kind with a poor outcome. So these malformations of cloaca are broadly divided into complete urorectal septum malformation sequence or a partial urorectal septum malformation sequence. So coming to our case, so incidence of persistence cloaca is 1 in 50,000, and it constitutes 10% of the anorectal malformation. Here we mostly see a single perineal orifice, and a large pelvic cyst with oligohydramnios with associated renal abnormalities is seen, and which is a result of which leads to pulmonary hypoplasia. Also, the colon is expected to terminate at a higher level. So we can see here, even in this MRI image, that the colon and the perineal distance is quite there. Also, it is a lethal condition with poor prognosis. So what are the most important investigations in a cloacal malformation is MRI, because it is important to identify severity of the cloacal spectrum. Also, accurate prenatal diagnosis allows more effective counseling, and the needed interventions are known to the couple. And also, a level of T1 hyperintense meconium signals helps differentiate persistent cloaca from the cloacal variants or urogenital sinus, which are comparatively less severe and where surgical outcomes can be good. Also, most of the cloacal abnormalities, which are of severe category, will present as anhydramnios. So associated malformations can be known on the MRI. So in this case, I felt that it was a good case because there was very early non-division of the cloaca, which led to a common sac called as cloacal cyst, and also the urinary ascites, which is most commonly from the fallopian tube drainage, was not in this case. And in this case, most probably it would be due to the obstruction. So autopsy, embryology, and review of literature gave us a closure. So learning points from this case: cloacal malformations always will need a multimodal evaluation. MRI should be ruled in at the earliest to reach a diagnosis for better counseling and management. Complete URSMS will present early on the ultrasound, that is late first trimester, which was missed in our patient, and are associated with poor outcome, mostly because the anhydramnios will be leading to the pulmonary hypoplasia, which will be leading to a adverse outcome. Also, fetal ascites and cloacal abnormalities is always a red flag. In our case, the ascites was quite huge. Even the size of the uterus was always 4 to 5 weeks more than the period of gestation. And also in cloacal variants, where the outcomes are good, fetal ascites generally causes postnatal surgical complications like matted bowel adhesions. Thank you. Thank you for a patient listening, and thank you SFM for giving me the opportunity to present my case.
Thank you, Dr. Soumya. Not just the imaging, but also the autopsy findings and the embryological basis did help us to get this case a little better. And your clarity of thought came through very, very marvelously throughout the entire presentation. Congratulations, it was wonderful. I now invite Dr. Washnik to take up the questions and answers, please.
So good evening, everyone. I think today was an excellent academic session. All the cases that were presented, they were complex and they were challenging, and they required perseverance. They required guidance from the seniors. But look how well my young guns have presented today. And even in the previous webinars, the cases were very, very complicated. And all the young guns, they have presented so nicely, so well. They have raised the bar for the other chapters. It will be a difficult act to follow. First, I would like to invite Mohit Shah sir for his comments on today's webinar.
Oh, you echoed my sentiments, Alok. This is marvelous. And the very fact that many of them are doing it for the first time, and yet there is so much of clarity in the thought, and doing complex cases, breaking them out into the time frame, and yet wonderfully done. Superb. It is quite impressive, and I'm sure this is just the beginning for all of you. Many more to go, and we want to see you on the center stage at some point in time. Please keep the good work going. Very well done. Congratulations.
Absolutely fantastic. And Purana sir, any comments you would like to make about my young guns?
You know, they're not just your young guns, they're everybody's young guns.
I'm feeling very proprietary today.
I know this is very, very wonderful. I think it's marvelous the way everybody is being tuned by you. I think it's marvelous how they're making this huge effort. And there have been some very, very significant points made by each speaker, including touching for the first time really dignified closure to an abnormal pregnancy in the third trimester. I think this is a subject that we need to understand more about. We have been associating with the Stillbirth Society of India for such programs, but I think it marks a fresh beginning which we must exploit in the future to make sure that we can do as much for these patients as possible in the perspective of the fact that the new act permits all of this. Beyond that, there is also this very interesting fact that as much of a case as we can work up, we should work up. And that is very, very important. If we miss out on, say, a bit of genetics here and there, or we miss out on an odd investigation, I don't think that should deter us from presenting anything, because the lessons to be learned are pretty much the same if an investigation was not done. And some of the cases presented this where there was an odd gap in the investigation, but we still managed the management pretty well. And I know the question box is full of questions being questions waiting to be answered by this. And the third extremely important point was I just love the confidence of the Delhi young guns. It is absolutely amazing. We've also had this chance to be able to incorporate people from the so-called Delhi NCR, the larger Delhi, and it's nice to see everyone together from all our little tiny surrounding towns as well, if I can still call them tiny. But all in all, a fantastic experience, a great learning experience, and I'm looking forward to the question and answer session.
And you must be especially pleased because everybody is stuck to their time. In fact, we finished before time.
Yes, I am very happy with that. Excellently done. Yes.
So that was testament to their practice, actually, how well they presented. No gaps at all.
Yes, excellent.
So there are a few questions. There are a lot of accolades for all the young guns who presented today. Some questions are there, so we will take them one by one. I would like to invite Dr. Chanchal Singh. She is a fetal medicine specialist, a very renowned one at Madhukar Rainbow Hospital in New Delhi. And Dr. Sumitra Bachani, who is the president of Delhi chapter of Society of Fetal Medicine and a fetal medicine specialist working at Safdarjung Hospital, New Delhi. So the first question, of course, we expect the young guns who have presented today to answer those questions first. Okay, I think they know their subject better than we do at this point of time. So Ayush, the first question is for you. Is there any correlation between the CNS findings and the polyhydramnios that you observed in your case?
So the mother had gestational diabetes. I thought it was mostly attributed to that. Otherwise, there was no evidence of cleft lip or palate. The stomach bubble was seen, the target sign was present. So there was nothing suggestive of a structural defect. We're still waiting for the genetics, but unlikely maybe that would be a contributing since we have gestational diabetes. So
Yeah,
I
but when there are severe CNS malformations, then the
maybe
fetal bone,
deglutition.
so the
Yeah, could
deglutition
be.
suffers.
Yeah.
So that could be one of the reasons why there's polyhydramnios. And why was this case not diagnosed at the time of second trimester? And could it be diagnosed at the time of second trimester? And the follow-up question will be, is it possible that at the time of anomaly scan, everything is fine, and then you see such severe abnormalities at the time of third trimester?
Yes, sir. So that is the challenge with these cases. I mean, I went through the pictures also. So this seemed more as a consequence of fetal vascular insult, and which are notorious to happen more in the third trimester. So I remember seeing the picture of the transcerebellar diameter from the anomaly scan that seemed pretty much unremarkable. The TCD was corresponding. So it does not seem like a condition that was maybe detected at that time. Although the posterior fossa changes seems to be part and parcel of the hemorrhagic clastic property transformation that must have happened. That's one possible hypothesis over here. So that's why third trimester always offers us an opportunity to go about our anatomical survey, irrespective whether we've done the anomaly scan or not otherwise. So that is what I wanted to bring for.
Very well said. Dr. Chanchal, what's your experience about the anomalies that appear first time at the time of third trimester scan?
Thanks, Dr. Alok. Good evening, everyone. Those presentations were actually brilliant and wonderful cases presented very confidently and an excellent summary. I mean, it was complete in terms of diagnostic workup, management, and outcomes. So congratulations to all the young guns. You really make us proud. Alok, coming back to your question regarding anomalies in the third trimester, it is being increasingly emphasized again and again that about 1 to 2% of anomalies will be seen only in the third trimester, especially the bowel abnormalities and the CNS abnormalities. So every scan is to be used as an opportunity to diagnose another anomaly, and any growth scan is not just a growth scan. And yes, in our day-to-day practice, we are increasingly finding problems in the third trimester because probably we have started looking at it more meticulously, as represented by both the part 1 and the part 2 of the Young Guns webinar.
Dr. Aparna, you must be dealing with the cases which present to you at the third trimester. Dr. Aparna, are you there?
Yeah. I'm there.
And so are there any challenges about how people go about for termination of pregnancy? This seems to be a very common question you must be getting every time you have these
Yeah,
kind of webinars.
yes. I think it's a big challenge in terms of management. First of all, handling patient expectations is a big thing because they've gone through this pregnancy and they're like almost expecting a good news when you're telling them that no, okay, further down this pregnancy is not going to be what they're expecting. I think that's one of the biggest challenges. The next thing is, of course, deciding what to do. Do we continue this pregnancy? Are they willing to go ahead with this pregnancy, or they want a termination of pregnancy? That's something again. So when we do constitute a medical board, we ensure that all of the stakeholders are there. So we have a pediatric neurologist on the board, right? And all the people who can affect the management of the baby postnatally are there to tell them how exactly would a baby do in such a situation. And when all of the stakeholders are there together with the parent and they think that, okay, this is not something that we want to continue the pregnancy with, then we go ahead with termination of pregnancy. And that is again a very big challenge in the third trimester. Like in this patient, I remember it was such a big challenge between me and Anubhuti. We had so much of discussion on how and why we can ending up doing a cesarean for her, but there was no other way out. But yes, I mean, so it's actually a burden on the system in terms of doing a third trimester abortions. So not just for the patient but for the health system as well. And we need to ensure that we do a normal delivery for such patients. So that takes a lot of effort. And we take risks. And so that is what has to be kept in mind when we are sending such patients for third trimester medical termination of pregnancy. Because it's not just about the baby, it's about the mother also. You're going to put multiple induction drugs, you're trying for a normal delivery, you might end up in a preterm cesarean section, which again would jeopardize the next obstetric history. So there are multiple things at play that we need to understand and keep in mind when we are managing such patients. And this patient was such an example where we had to end up doing a cesarean section, and we were not very happy with that particular outcome. But that's what it is. We have to take those chances.
Actually, when Ayush sent this case and we had a discussion, there were, gaps in the investigation simply because the patient turned up very, very late. And we included this case especially to show people that life is not perfect. It's not every time you will be able to manage to send investigations and everything. And based on those imperfect things, you will have to make imperfect decisions. And sometimes they are going to go in the wrong way anyways. Khurana sir, what's your experience? How life can become hard so much?
Well, we've even had one report of a patient having a cardiac arrest because of the potassium chloride that was used for stopping the fetal heart. And that was one of the most heart-rending situations I've ever come across. This was very early in our practice several years ago. And at that time, we weren't even sure about the legal status of intracardiac potassium chloride. So things like that were very, very troublesome to start with. Now, of course, we realize that we always do it in an institutional background and we respect potassium chloride for what the drug is. The second situation is if a member of the board decides that this pregnancy ought not to be terminated, can the patient appeal further? Because the next step of appeal according to the act is really the courts of the country. And by then it would be too late and it would be time for delivery if a decision were not taken. So we do need to modify our act to make sure that even decisions taken by the high courts have to have a time-bound decision making. That is the next step that we never realized we would ever need to face. We have had situations where within boards, not necessarily the ones in Delhi, because we've had a very positive approach to this, but in other states, where one person decides on the board that they don't want the termination and the board decides that there will not be a termination. And that's really hard on patients because in terms of cardiac defects, it places a huge burden. And most governments, apart from Kerala, are not willing to accept the cost of operating such children and the cost of these surgeries. So these are things that still need to be addressed and which we really have to do in the near future.
Thank you, sir. Very insightful comments as always. The next question goes to Dr. Panchami. She presented very well on the CMV infections. So the question that is being asked is why was only, I think this was a mistake in reading during the presentation. But why was only the cytomegalovirus and parvovirus sample was sent, not the whole torch? I think everything was sent.
So yes, everything was sent, but we particularly asked for CMV because the patient's avidity was high to it. So we wanted a definition for the infection or the, because it's the most common infection. I've already said it's 1 to 4%. Parvovirus, again, for fetal anemia, very common. And she was immune to rubella and herpes as well. So we did not want to focus that much on it, but we had high clinical suspicion to send this sample.
And why not cord blood CMV PCR?
Sorry.
Why was the cord blood not sent for CMV PCR? Because you had made a diagnosis earlier.
It was sent. We have sent the cord blood itself for PCR. I've sent it.
And the question is how to screen for CMV in pregnancy. This is a
So IgG, IgM antibodies. If IgM is present, is positive, we think of recent infection. IgG is present, we either think of past infection or recent infection. Then we have to go for avidity testing, like I said. So avidity will talk about the how long ago it happened. We can come to know about the duration of the infection. And in this late gestation, if it is IgG positive, it's again suggestive that it's probably first trimester or possibly a secondary reactivation.
Okay, there are some questions about the valacyclovir therapy.
Yeah. Can I make a comment here, Olive?
Yes, Dr.
Yeah. So that question was quite pertinent, that why not everything was sent. So I think Panchami's presentation was quite clear. They investigated the mother. The parvovirus, IgM and IgG was negative. So there's no question of the baby acquiring that infection. And the mother was immune to rubella. So maternal torch IgM, IgG testing is important because you will test only for the viruses that the mother is carrying an antibody to. And it's not the IgM, because IgM can become negative within 2 weeks after primary infection. So whatever the mom is positive for IgG, those are the infections. So it should be directed testing. It should not be that you randomly send the fetal blood sample or fetal amniotic fluid sample for any test that you think of. So it must be directed.
Yes, absolutely.
And if this valacyclovir therapy, Dr. Sumitra, should we run it for 9 months? And how do we initiate in patients in which the diagnosis is not confirmed? Because the PCR is not there.
Yes. So, sir, in this valacyclovir, since around 2020, it has been suggested that the studies are suggesting we can give it in a dose of 8 grams per day. It is safe in the first trimester. It is safe in the second trimester. It is safe in the third trimester as well. But of course, it will have the best outcome if we give it in the first trimester. Now, there is an original article on the AGOG website. They have talked about how to give and when to give and to stop. So in their article, they have mentioned that whoever they have screened, if they find that the patient was screened positive, they have to give valacyclovir to prevent the vertical transmission, so that they do not have baby getting affected. Because transmission, even if it is in the first trimester or the third trimester, the affection is more of the fetus in the first trimester, as in it will continue to have the whole pregnancy to develop the congenital cytomegalovirus. So from the first trimester, it is definitely more satisfactory to give. And they have asked to continue until we give 21 to 22 weeks. And that's when they want us to look for amniocentesis as well. There are papers suggestive that 21 to 22 weeks would be the best time, because if there is CMV positive in it, then we can stop valacyclovir. However, if the DNA PCR is positive, and now there are ultrasound signs as well of the congenital cytomegalovirus infection, then we have to continue it. And in case the patient has declined amniocentesis, then we must stop by 26 weeks. This is the guideline that they have provided.
Mitra ma'am, your comments on how to work out this valacyclovir therapy for such patients in CMV?
Yeah, thank you. So we have used valacyclovir, and as Panchami very nicely explained, that there has to be a diagnosis of fetal affection, or diagnosis of first infection, and if at all affection is there, like with ultrasound findings. So what we do is we need a positive CMV PCR in the amniotic fluid before we say that we are going to start the treatment. And of course, the treatment has to be continued till delivery. And if the neonate is found to be positive, of course, then the neonate also needs treatment. The other thing is that valacyclovir also needs monitoring. You have to get the LFT and the KFT done for the patient. I mean, because this can be a hepatotoxic and a renal toxic drug, so it does need monitoring, and it is an expensive therapy. Once we had a very unique case that there was this mother who had 2 babies who were CMV positive. They developed meningitis afterwards. Throughout pregnancy, she had no monitoring. She came to us in the 3rd pregnancy. Her previous 2 babies were diagnosed to be CMV positive, meningitis, in AIIMS Delhi, and they had both died. And this mother was so anxious in her 3rd pregnancy likely it had been a CMV reactivation, but I mean, reactivations actually don't cause so much of infection. And then what happened in the third pregnancy, she was so, anxious, although she insisted that she would like to do a CMV PCR. We did it for her, it was negative. But she said, no, you have to put me on treatment. I've lost my baby. So in that, there we have given, valacyclovir to her. The third baby was absolutely fine. So, I mean, CMV, I'm still trying to understand. And so that's what I said, that few cases we've given valacyclovir, we've had good outcomes. And I think one more thing I would like to add is when you ask for CMV, like a torch is like being done right and left, like, a CBC. And you suddenly somebody asks for a torch in the mid gestation. I mean, there should be a proper guideline that when should you ask for a torch test in pregnancy? It is, and from a standardized lab, I really want to make this point because we get so many reports and incomplete reports. Sometimes it's just IgM, sometimes it's just IgG, done at any point whenever somebody feels like. So I think that part one needs to be very, very, sure about as to when and what kind of test. It should be ideally be a paired sample when you ask for it. So that's what I wanted to say.
Khurana
Thank
sir,
you.
what's your
Thank you.
take on CMV testing and
Yeah.
management?
So we've had so much inputs on CMV infections in the last 3 years. So it's pretty much obvious that we cannot disregard cytomegalovirus infections in pregnancy on a routine basis. And I'm really wondering whether the time is right now for a routine screening for cytomegalovirus when we do our initial screening in pregnancy, when we do our blood group, blah, 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 etc., etc. And I really want to know what Dr. Parna Sharma thinks on this, whether we do need a change in policy now on CMV screening in early pregnancy.
Thank you, sir. Sir, I think we've had recent discussions on this. And so I think the evidence currently is in between. I think the evidence, and definitely, but in individual practice, I think there is some merit. I mean, personally speaking, I have started to some extent looking for CMV in the preconceptional period because, it somewhere decides, okay, if you are immune, if you're CMV immune in the preconception period, it would mean that, okay, you will not be affected by the CMV because reactivation, as we know. So what Sumitra's case is like something which is very out of the box, but generally speaking, if you're CMV immune, your fetus will not get affected by CMV. And if you are CMV not immune, you will take precautions in this pregnancy. The point of universal screening for CMV, the proponents of universal CMV screening, they do advocate this particular path because they say that if you are immune, you're sure. If you're not immune, you'll take care. That is what they say. So I think there is merit in thinking about it because we, like you said, you cannot just ignore CMV anyway. It is the common cause of one of the most common causes of newborn deafness, and we cannot ignore it anymore. So in my individual practice, I am not here to say that this is a guideline, but I have opened my eyes and I've started looking for it in a big way.
Dr. Chanchal, you must be having very demanding patients. So how do you handle CMV and DOJ?
So actually, what Aparna has said is right, that it is somewhere you have to draw the individual. So the guideline is somewhere, there's some evidence that yes, we know that CMV is the commonest cause of congenital sensory neural deafness, but even in our practice, we have not started routine screening because the problem with the routine testing is the inadequacy of the serum serology to diagnose primary infection. And the problem with the reactivation is that if it occurs in the first trimester or in the periconceptual period, the sequelae would be equally bad in case there is a fetal infection. So I think we'll just have to wait. But as of now, we are not offering routine CMV screening in our practice. All the cases that we have diagnosed of antenatal CMV, there's 6 odd cases, but they were because we saw findings and then we went back and tested the mother and did an amnio and checked the fetus. But yes, we have not screened them. And there are 2 aspects to valacyclovir actually. What Panchami was talking about was once there is maternal primary infection that is suspected, and then you want to prevent mother-to-child transmission. And that is when you put them on valacyclovir right from the first trimester, check that 17 to 20 weeks, do an amnio. If it is negative, stop. And the other aspect is treating an infected fetus with moderate findings on the ultrasound. So I think one must have a clear distinction about these two. And there is no question of starting valacyclovir without proving fetal infection. So that question in the chat box actually asks that the patient is not willing for amnio. Can I start valacyclovir? The answer is no, you can't.
Yeah, just on the basis of imaging, you cannot say that it is due to CMV, and especially the signs they are described, they are very non-specific. Okay, so let's move on. And there's a request for Dr. Saloni that the patient information leaflet that she showed for CPAM. So,
Yes, sir, I'll be able to share.
yeah, so maybe you can send a PDF to Vishal or to me. We
Yes,
can
sir.
share it with people.
Okay, sir. Okay.
Okay, so that seemed very, very nice. Very nicely. And another question is, what is SAS score? This is not related to actually the fetal medicine part.
Yeah, it's the neonatal score that they do to check the grunting, Silverman-Angelman scoring, to check the chest wall retractions,
Yeah, the
grunting,
respiratory
nasal
distress
tearing,
they want to
respiratory
check.
distress score.
Yes. So, and there are a lot of accolades for you. Very, very nice presentation you had.
Thank you. Thank you, everyone.
Dr. Alina, so in your case, you had a case of GCT, and was the kidney enlarged? One of the kidneys? It did seem to be a bit enlarged, and why was that?
Yes, sir. So kidney was enlarged, but it was not invaded by the mass. So most probably it was because of the mass effect, because it was such a huge mass that it was compressing the kidney. It was obstructing the outflow of the urine from that kidney. So that's why it was seen to be enlarged on the scan.
Yeah, so sometimes it also compresses the renal vein and the kidney becomes edematous. So that is sometimes the cause. And is there any way to predict whether these masses, they are malignant or benign antenatally?
There is no particular way to say whether the mass is malignant or benign without having the histopathological diagnosis, but there are always signs that we can look for to know whether the mass is benign or malignant. The mass will be smooth outline of well circumscribed mass would most probably be benign. When the mass has a huge vascularity and causing hydrops, it might be a malignant mass. If it's a rapidly growing mass, it can be malignant. So these are the things that we have to look for. If in my case it was diagnosed very late, we could not do serial scans because it was very close to delivery. But if you end up finding a mass, let's say at 28 week, 29 weeks, do serial scans, look for other signs of hydrops or growing mass that can point it to malignancy.
So the upshot is that antenatally, it's very, very challenging to say whether the mass is malignant or benign. And in fact, the masses that develop in the fetus, even if when they are malignant, they behave in much different way that they would if they occur in the postnatal infancy or young adulthood phase. Some of them, they totally regress with time, even if they are malignant. So we simply have to wait and let the baby be born, and then we'll do the whatever is the best for the fetus or the baby. Okay, I think we have covered all the questions.
There's one more question from Dr. Ratnapuri on
Okay,
genetics. Yes.
Yes. The relevance of genetic variants in CPAM. Dr. Saloni, Dr. Aparna, your cases.
So I think Saloni, you're there now?
Yes.
I don't know. I think Pam, I think it's best that you take this question because this is something that we looked up in the literature. So we found that there were some associations. Typically, this is what we counsel, that it's fine, don't worry about it, and this is what we have been doing till now. But increasingly people are testing and they are found. So that's what we say, the difference between association and causation. Let's not attach too much importance to it. So I completely understand, but I think this is some new knowledge that we have to put forth. So that is something that we kind of found on the literature, but I think you are the best person to comment on it.
No, I actually was asking because I have not reviewed it. I was truly
Yeah, so
asking
these are
because
some
she
of
would
the
have
reports.
reviewed it.
Yeah.
Yeah, but what my thing was that I have never done genetic testing for a CPAM, and I don't think most of us have. But would it impact the management? Because it's a anomaly with a good outcome. And I don't think that most likely these, I'll also have to review it, and maybe I'll review it and then come back and inform everyone whether they are somatic, what is the impact. Sometimes you have somatic variants at the site of the lesion, which may not really impact it.
Yeah.
Now, I do know only one gene really sprung to my thing when she went in that list was the DICER gene, which I know is associated with somatic cancers. Okay,
Yeah.
very rare cancers, where also it's just an association, because I know we worked up one child extensively, and that's when I reviewed it for cancer. But maybe
Right.
I only wanted to bring it to attention so that we don't start, routinely testing and then putting prognosis to that.
No, absolutely, ma'am. And I think CPAM should be left as CPAM.
I
Let's
also
not make
think
it.
so.
I completely,
Yeah.
and that's the reason why we also insisted on presenting the pediatric surgery video here, because it's
Really
something which is
nice.
completely curable and treatable. So it is just a lesion that needs to be removed.
Yeah.
So we must, and believe me, all of these patients, currently we have around 4 or 5 patients who have huge CPAM which look dangerous at the time of presentation. But eventually, I think that, and most of these patients come to us for termination of pregnancy, given the size of lesion. But we have to have the faith that these are ultimately hematomas. These are going to come out. So I think that's the important message, and we don't want to really attach any genetic connotation to
Yeah.
it. And I agree with that
Great.
side.
Thanks. Thank you. Yeah. Yeah. I second Dr. Manna's opinion. They look very, very dangerous. And at surgery, almost 2/3 of the lungs is removed. But you do an X-ray a month later, and that remaining small apex has expanded to fill up the entire lung. And these children have normal day-to-day activity and normal routine. So I think, yeah.
Except when they develop hydrops, then it becomes challenging.
Even then, sir, I mean, for example, the case that she presented, that they aspirated and it just resolved.
Correct.
Yeah.
It is
Even if they
amazing how
develop
it shrinks. Yeah.
it's temporizing measure that you need to do. So even if they develop hydrops, let's not lose hope on the baby. Do something to kind of, pass that
Prolong
period
the
of
gestation.
gestation.
Yeah.
And take the baby out.
Yeah.
So final words from you, Khurana sir, then let's wrap this up.
I am always amazed. And what also fascinates me is that increasingly, a lot of our attendees are sitting through all the question and answer sessions as well, which means we're being able to engage their interest to know more about every single subject. So it's not just that the young guns are performing brilliantly, but also that they're provoking thinking and provoking attention, and that each one of us at every level wants to know more and more about these conditions. I think we really need to congratulate ourselves at the Society of Fetal Medicine for truly bringing about an international movement where so many people at so many levels with variable degrees of socioeconomic statuses are getting the best of treatments in our part of the world. So congratulations to all of us.
Congratulations. Wonderful.
Yeah. So thank you everybody who joined us today. Thanks to all my SFM Delhi team, and big thanks to Khurana sir, Mohit sir for always encouraging us to present all these kind of programs. Good night, everyone. Young guns, well done.
Good night.
Thank you and good night.
Good night.
Good night.